there? Yes? Hopefully. Okay, great.
Yeah.
So I wanted to talk to you a little bit about just approaching care. And this sort of talk in diversity, equity, and inclusion around 2SLGBTQIA+, or as we generally say, queer, because it's just easier. In the queer cultures, the common theme is a glossary first, what all of the different letters mean, like what all of the different pronouns are. And I definitely saw some questions about that, and we're definitely going to get to that. But I want to actually step it back because it's a little bit more foundational from that. So when we're talking about queer families, when you're talking about queer care and healthcare, especially, I want you to understand that we're talking about a population of folks that have been marginalized for a very long time. And these folks also have intersections of other marginalized identities or not. So it's a really, really diverse group. We're talking about, anybody can be queer. So you can have somebody who's queer and disabled. You can have somebody who's queer and Black or Indigenous or a person of color. You can have somebody who is queer and very low income. And on and on and on. So when we're talking about queerness, we're not just talking about one group of people just with one thing. So it kind of gets lost when we put people into like a queer box. and it's also important to understand that with those identities, you may have people that aren't safe to be able to disclose their queerness. And so we have in this country a very long history of making it very unsafe to disclose or to live as a queer person. And in other countries, it's currently still punishable by the death penalty. So when we're talking about research and we're talking about demographic data, you're talking about asking people to self-identify in a way that could possibly kill them. And unfortunately, in the United States, it's also not legally, it's not illegal, and there's no death penalty through the court or the government, but there definitely, depending on where you live, is a death penalty for living as a queer person. 2 weeks ago, a young man in my city was just murdered because he went to a party and he met somebody there who found out he was queer and killed him. So, good morning. Oh, well, it's morning for me. Good afternoon for you. On that tragic note, there is a lot wrapped up in this conversation. So I want you to, though, start with where we're coming from. When we come to you as a healthcare provider, and if we tell you that we're queer, you're already getting a huge amount of trust. You're already being granted a huge amount of vulnerability because there is a significant amount of mistrust on behalf of the queer population of the medical complex, especially in the United States. The last thing that I want you to keep in mind is that something that's really important for us is the HIV, the AIDS epidemic it feels like forever ago, but understand that it wasn't that long ago. A lot of us remember it, and understand that hospitals refused to treat people who had HIV or who had AIDS, and they died because nurses didn't want to touch them, or because people believed that this was God's punishment for being queer. So understand that you're already coming in at a disadvantage of getting and having the trust of the person that you're trying to help. And I'm not saying that you feel that way, but you have to understand that as a community, that's been our most recent wild upset and upheaval as experience with coming to the hospital and coming to care. So in all the other things that we'll talk about too. I wanted to talk about power dynamics. Power dynamics are really important. So understanding where you are in the power balance in the context of a healthcare setting. So when we talk about power dynamics, there's a couple of different things. There's power and there's influence. And so there's formal power and there's informal power. So the formal power is actually the actual ability to control the actions of another person, even if it's something that they don't or wouldn't normally do. So informal power is the socio-cultural paradigms and expectations where if somebody will listen to me and believe me more because of the color of my skin than they will somebody else. That's informal power. And that's important that as providers, we recognize when we hold informal power in the context of any setting, but especially in the context of a healthcare setting. And if you are helping someone who is queer and you are not queer, you have some informal power in that setting. And again, with intersectionality, that power balance is not always really clear and easy to sort of parcel out. So it's important that you explore the places where you hold power and where you don't, informally and formally. So the formal power means you have the actual ability to punish others for not doing what you've said. And as a healthcare provider, we carry that formal power because we can discharge them from care. And so you follow the care plan or you get marked as a non-compliant patient, right? You follow the care plan or you take the medicine or you do the thing or I'm not going to help you, or I'm going to, deem you incompetent and appoint a state guardian, or, there are lots of good reasons for being able to help somebody who may not be able to help themselves, but there are unfortunately also people that take advantage of that power dynamic. And usually it's not intentional. It's unintentional, this advantage taking of the power dynamic, because we get to a place where we are very sure of what the next right course of action is. And so we really want to help. And we see this person's resistance and maybe don't understand it. And we think they're getting in the way of their own healing or helping or recovery. And so we can take advantage of those informal or formal power balances in order to try to help them. It's very important that we recognize this and we take a step back and we evaluate what we're doing and why we're doing it. Now, the other side of power dynamics are influence. And so that's actually a little bit different. The influence is the ability to sway the thinking and actions of others and encourage them to act, but they act on their own free will. Influence can impact others' thoughts and feelings and choices, even when the influencer is not there. And so influence tends to be, I guess the easiest way to say this is like Instagram influencers, right? So this person you follow has all of these great things that they say and all of these really smart ideas. And gosh, their kitchen is so well organized and these things are so beautiful. So I want to do things like this person.
Computer audio.
And so when we're talking about influence can be beneficial and it can be harmful. It depends on the influencer and their intentions with initiating that influence. And so when we're talking about client care settings, I want to talk about what it means to be in the position of power. And like, Spider-Man says, with great power comes great responsibility, right? And so as a healthcare provider, you are already in a position of power. So your responsibilities, this is a long list. I know it's overwhelming, so we're just going to go through it and then get on to the other things. I want to know, what you think, and if you want to be interactive, if you feel like it, if you feel like unmuting and sharing your thoughts, I would love it. We don't have a ton of time, but I would like a couple, be happy to have a couple of your thoughts. Understanding what the expectations are in your environment. What do you need to consider before you step into the client care, into your clinic for the day, into that room? Or if you're doing home visits, what do you need to know before you step into their home? And what are the expectations of your area? Like, what do you are you considered like having informal power in where you live? Are you considered not having informal power where you live? And how do you relate that lack of informal power in your community with your carrying of formal power in your position as a healthcare provider? It's a complicated question, and I encourage you to explore it if you haven't already. I'm sure you have, but I like to get started here because this makes everything else make more sense. And then how can you make sure that you're acknowledging your position of power? So where are you in the power dynamic? You know, what are the structures? Do you have a boss who tells you what you can and can't do? You have to follow protocols, whether you agree with them or not. Or are you your own boss? Are you making those protocols for other people? So making sure that you're understanding just where you are in that power dynamic, and then acknowledging that position of power when you're coming into a client-facing setting. So if you're stepping into a patient room, or if you are, sitting down with your client as a lactation care provider for a consult, making sure you say, "Hey, this is the elephant in the room. I have this power, but I really want to make sure that I'm acknowledging that I understand that, and I'm going to make sure that your thoughts, feelings, and needs are heard and acknowledged, and that you have the autonomy in this situation. So I'm going to help you with the tools that I have, but I want to just acknowledge that I know that I have power here." And in research that we have, and we have quite a bit of research on the topic, just the acknowledgement of power or bias or cultural differences in a client care setting makes a huge difference in the outcomes and in the trust and in the confidence of that patient with their provider. So that can go a really long way if someone says the obvious thing that both you and the client know, but I think it makes people uncomfortable to say out loud. Anyway, if anybody has already explored this, if anybody would like to speak to this, would anybody care to unmute and share? I can't see the chat, so because I've got my screen sharing on, but if
I'll keep
anybody
my
wants
eye on
to
the chat.
Thanks. And Suzanne, will you tell me where we are on time?
Sure. We probably have about maybe 25 minutes.
Perfect. Great. I know I kind of got heavy, deep, and real straight away. That's okay. We can keep going. And then if anybody has thoughts, please pop them in the chat and let me know. Okay, so let's talk gender expression. Now, I need you to know that gender and sex are different things, and that sex and gender don't always align. Sex assigned at birth and sex and gender are also all different things. Is everybody following so far? So far, so good. Gender is how your experience of the world, the way that you receive things and then experience them, and then you contextualize them within your affiliation of social grouping. It's also a complete social construct. It's not, there is no way to scientifically find your gender. It is a construct. So a lot of times you'll see, I'm in queer communities. And so there's a lot of times that you'll see on Twitter, somebody saying gender's not real. And that is a topic of debate within queer communities. And it's not really for people who aren't queer to weigh in on, but it is a social construct. It is an experiential thing. So it's not definable by a test. For example, there isn't a diagnostic criteria that decides your gender for you. There is your experience and your expression. And so you also should know that people's gender and the gender that they express outwardly have nothing to do with one another. Just because somebody wears dresses and makeup and heels doesn't mean that they identify as a woman. Does that make sense? So let's talk about terminology, because there were a lot of questions about this. So the terminology of gender expression, I want to kind of go through some of the things that you may not have encountered. I skipped the obvious, the binary, male, female. And so if you're talking about somebody who's trans, you're talking about somebody who is different than the sex or the gender, it depends on the person, that was assigned to them at birth. So for me, I'm trans, and that's because my gender is not the same as what was assigned to me at birth. And so I was assigned female at birth because of my gonads, they're internal. So, the doctor said, it's a girl, and I was raised as a girl, and there's a ton of socialization that goes into that. And there's a ton of socialization and internalization of what's appropriate and what should be for a woman. I'm sure as if there are some women on here who can agree and identify with that. When I began to interrogate my gender because I felt something was wrong, I eventually came out as trans when I felt safe to do so, which is an important thing for you to hear because it's not always safe for people to share, but that doesn't mean that they are not trans. And if you can say trans or you can say transgender, or we don't say transsexual anymore, although you might hear that coming back in some queer communities. It's that's a topic of debate, so I left that one alone. So you'll trans is safe. Just go with trans. If you want to say transgender, you say transgender, but not transgendered. That's not correct. And so you might hear somebody identify as non-binary, or they may say NB or NB. NB is a colloquialization of the initials NB, which stand for non-binary. Somebody who's gender queer is somebody who is still, either doesn't care to define their gender or doesn't have an answer for you yet, is still interrogating their own gender, and that's how I identified for a long time. Gender fluid is somebody that actually their experience of gender changes all the time. And that is a documented phenomenon that's happened to people for a long time. And so that gender fluidity means that one day you wake up and you have a sense of gender as you're like, yes, I feel like a woman. And then the next day you wake up and you may not have a sense of gender at all. And it's disorienting to say the least, and it can cause dysphoria, which is something we'll talk about. And sometimes you'll wake up and you're like, nope, I'm very clear that I'm non-binary today, or I have a little femme, a little masc, and so on and so forth. And it can be really hard on the people who are gender fluid, because something I also want you to know is that people who are trans don't choose that. It is something that we experience, and there is not enough good research on it, but we also know that there are a lot of different things that go into a person's experience of gender in the world. And honestly, if there are plenty of us that if we could choose to not be trans, then that great, because we would deal with a lot less nonsense. But for me, I would still choose to be trans, because living in my truth and like being able to be my absolute true self as much as I can is what saved my life. So it's not like you can say, oh, I'm going to choose to be a woman today. That's not how it works. Any more than you choose the gender that you have right now. And so you may hear people say that they are agender or genderless, which means that they don't have a sense of gender, that they don't feel particularly aligned with any of the genders on the spectrum. And that's just as acceptable as having a gender. So, if you're forced to pick one from a list, it's really tricky. And so then there is this one, which is a swear word. So I'm going to just leave it on the slide in case you're at work. I don't want to get anybody in trouble. But that's a recognized gender. And it's people who identify this way typically have chosen their identity terminology, but not their identity. So people will choose identity terminology that pushes back against the system. And so it is an act, it's a mark of activism for gender equality. And then gender anarchist is similar, in a similar vein. And so those identifiers are selections, but your gender experience is not, if that makes sense. So when we're talking about this, I want you to think about like checking your cultural humility and like whatever feelings that just came up for you hearing all of these words, right? I don't have all of these words for gender. It just used to be simple. And now I have to learn all this stuff. Like, can't we just pick one and be done with it? And it's like, there's a lot there. So remember that this is, if this is not your culture, if you're not part of the queer community, then approach this community and culture as you would any other culture, with humility and an openness and willingness to learn. And also, you don't need to understand the reasons for why people do things. You just need to respect them. And also checking your privilege, if you can find clothes that are in your size, then that's a privilege. If you can find clothes that make you feel good when you wear them, that's a privilege. If you can find, go and buy makeup without getting weird looks, or things yelled at you, that's a privilege. And vice versa. If you can find, if you're a man and you can find men's clothes in your size at the men's store, good on ya. That's a privilege, So understanding that there are little everyday aspects that confer privilege, and privilege is usually not noticed by the people that hold it, but it's very obvious to those that don't. And I'm sure that I don't need to go into a long speech about that, because I'm sure that that's been covered before. I hope that that's been part of your learning already. Um, and so gender essentialism happens here in this space a lot. And it's considered hate speech. And so when you say, okay, that you have internal gonads, you have a uterus, you have a vagina, so therefore you're a woman. I don't care what you want to call yourself, you're a woman. That is gender essentialism. That's hate speech. And so if you're saying that, understand that that is actually legally identified as hate speech in some states, not all states, but it will be received that way by the community. And so trying to define someone's gender or sense of gender, or trying to define someone's sex for them, it is an act of oppression and violence. And so the consequences for that are extremely harmful, and they include death by suicide. In 85% of cases of dysphoria that go untreated, they end in death by suicide. 98% of the queer community who identifies as trans or non-binary or gender non-conforming, 98% of us have had suicidal ideation around our experiences of identifying this way in our society. And so you're looking and talking to people that already know that all of the things that you might want to say. So let's go to pronouns. This is my ABC glossary. There are, of course, she, her, and he and him, and then most commonly they and them. Personally, I have been known as she and her for so long that I don't like to deal with trying to correct people. So I go by she and they. I personally don't have a particular preference, but that's actually unusual for the queer community. So if somebody uses they, them pronouns, do not assume that you can also use a different set of pronouns for them. So I know that there were a couple of questions about pronouns and also identifying your pronouns, which I thought was a great question. And so I will get to that too. I have a whole slide of everyone's questions, and I'm going to take them one by one. But hopefully this starts you off on that answer. And so there's also they and zim, they and z and they, and they and them. So these are alternative pronouns. And then there are also something called neopronouns. There are a lot of neopronouns. I don't expect you to be an expert in neopronouns. If you have a client who uses neopronouns, then it's going to be a practice session for you before consults or before visits, because once you find out what their pronouns are, you can look them up in Google and you'll get the full conjugation list for each one, and you can absolutely practice. And it's really interesting. There was a study out of Sweden, and then they did another study out of Denmark, and they looked at and another one just came out of Singapore. They looked at healthcare providers and other people in positions of power practicing pronouns. And when they started practicing pronouns, not with clients, but with their families or friends or colleagues, they had a ripple effect. So when they said, "Oh, can you help me practice? I want to talk about this person, and they use they them pronouns, and I need to practice so that I can get it right when I'm working with them." And when they did that, the colleague that they asked and practiced with actually started to view, pronouns outside of the binary more positively, and then began to practice using them. And they found in multiple places on multiple scales this repeatable effect that when you start to practice out loud and you identify that this is something that you're embracing, then you actually influence those around you. We also found out that the opposite is also true. When people refused or rejected non-binary or outside the binary pronouns, then those around them also started to reject them and view them more negatively. And so you have a very important opportunity, especially if you're feeling nervous about pronouns. My dad's 74, and my oldest child is non-binary and uses they them pronouns, and he is trying so hard. And the most important thing to my kiddo, and I've talked to them a lot about this, is that he's trying. And he's like, "I'm never going to get it right. Yeah, they them. Well, I'm never going to get this right, and he's trying. That's not the way that I would approach it. I ask him to just like say sorry, correct himself, and move on. But he's 74 and he's my dad, so we give them a pass. When you're working with a client and you're not their immediate family, when you slip up, and we all do, even queers, no one's an expert, it makes a difference if you just quickly apologize and move on. Just don't make a big deal out of it, because otherwise you're then making you feel better for your harming of us. That makes sense. So if you refuse to use pronouns, or refuse to ask about them, or refuse to learn them, then that's on you. But I think if you're practicing and you're trying and you make a mistake, that's okay. And it's always best to ask. Just say, "What pronouns do you use?" Or you can say, "I use she, her pronouns. I use they, them pronouns. What pronouns do you use? What pronouns should I use when I'm talking with you today?" And I don't want you to say, "What are your preferred pronouns?" Because when you say preferred pronouns, it infers that it's a choice to be identified as in the way that we are. And we've clarified that gender is not a choice, right? It is an experience. And that really is dismissive. And anytime I see that on an intake form, I appreciate somebody is trying. I think that trying is great. And I know immediately that they're not all the way up to date on inclusivity measures. That makes sense. What questions do we have about pronouns, apart from the ones that, if you sent your question in advance, I'm going to get to it, but is there anything else that's come up so far? Maybe Suzanne could let me know what the chat is, or if there's anything in the chat.
Yeah, no, no question. I think nothing's different than what was sent in advance.
Okay. Perfect.
Kind of getting into the maternal health and how to address mama and that kind of stuff.
Exactly.
Yeah.
And so actually we'll go there first. I have a whole slide on this, but it's later. Exactly. The othering in maternal health, in what I say perinatal health personally, because perinatal is inclusive, and it doesn't leave anybody out. And if I used to work for, as a trans, non-binary, actually gender fluid person, I used to work for and teach classes, parenting classes for a hospital through the Center for Women's Health. And that felt bad because I know that we're not helping just women. And it doesn't mean that we aren't helping women. It just means that we're helping more than just women. And so if you had to go to a clinic and you identify as a woman and it said men's clinic, are you going to feel comfortable there? Are you going to feel like they know what your needs are and that what unique needs that you have? Um, there are people that I help with lactation who have external gonads and who don't traditionally have all of the pieces you think that you would need for lactation, but that's not true. It's a hormonal process. With the joy of modern medicine, we can help any parent um, breast or chest feed or body feed their baby. But it's hard to even step outside that your your space of wanting to do this and having a goal, it's personal, to ask someone for help if you have no idea what you're going to be met with. So if you're going to be met with like, oh, ew, no, then that's going to feel awful. And so that vulnerability piece, the reason that we do all this work to identify ourselves as inclusive and we take these trainings to understand how to be more inclusive, to meet needs of people, is so that we can put up a sign that says, hey, you are seen and you are important and you are safe here. You can come here for care. And I think at the end of the day, that's where we all align. That's where we all overlap as perinatal healthcare providers. And that's the thing that I want you to keep in mind every single time you see maternal or mothers or moms group or breastfeeding. Think about who's not included in that conversation. So I'm going to go ahead and skip this informed consent, except that I want you to understand that most providers think they're getting informed consent for interventions, that roughly 20% of patients feel like or report that they feel truly informed before making critical decisions in their care. And why this is important in trans and non-binary and gender non-conforming care is because if you don't have all of the knowledge and information about how to care for somebody who is on HRT or hormonal replacement or hormonal affirmation therapy, then you may not be giving them all of the information about consent. So it's on us as providers to know how processes are different when we have gender affirmation therapies on board and at play. Okay, so we talked about that cis normativity just now with the maternal health thing. And what I want to know is I want to do this before we get to the questions. I want you to do this little test. So if you have a piece of paper, or you can do this mentally, but I don't know how to do. It's a lot of math, so it's not a ton of math. But I want you to give yourself 1 point for every item on this list that you can say is true about yourself or your whole practice. And if you're in charge of the practice and it's true of your whole practice, you get an extra point. So if you have taken a trauma-informed care training, give yourself a point. If you have taken a motivational interviewing training, give yourself a point. If you have taken a cultural humility or bias awareness or diversity, equity, inclusion, whatever title, if you have taken a training about unpacking your bias and how you interact with other cultures, give yourself a point. If you have taken more than one, give yourself another point. And if you acknowledge your areas of bias and privilege, both within yourself and outwardly with others, give yourself a point. And if you offer information to clients in individualized formats, I know those snippets are enticing. It's so much easier to make a care plan if you can just copy and paste. But have you made sure that you're individualizing your care instructions and information? Give yourself a point. If you practice shared decision making with your clients, give yourself a point. And if you have visual aids and use pictures as well as words to describe things, give yourself a point. And if your written information and consents are at or below a 5th grade reading level for the US, or use other health literacy standards, give yourself a point. Remember that we have a population that doesn't feel comfortable or safe engaging with healthcare a lot. So you want to make sure that you're not assuming that people understand healthcare terminology that seems ubiquitous. And if you acknowledge the imbalance of power in your client care relationships, give yourself a point. Okay, now add up your scores. And we have a scoring chart here on the side. And so if your score was 1 to 3, you definitely, more work is urgently needed. So you've identified some blind spots, which is great. Good job, because now we know about them. So now we can do something about them. 4 to 6, it's time to brush up, maybe take another training. Good job, you're already here, yay. And 7 to 10, keep up the good work. And remember that this is an ongoing process, and none of us are ever going to be completely experts in someone else's culture. You just can't, because it's not your culture. So we always want to approach with humility and an open mind for learning. Even if you're like, well, I already know this because I learned this, but I'm not hearing the same thing from you. So maybe you're wrong, or this person was wrong. No one's wrong. People are just very different. And so just, oh, okay. So sometimes it's this and sometimes it's this, both and instead of either or. That makes sense. Okay. I wanted to do another time check. I want to make sure I have time to get to questions. I'm going to do it this way.
Yes. We have about 15 minutes.
Perfect. So I'm going to get to those list of questions, and then I am going to open up for more questions that I didn't answer.
Thank you.
Hold on just one sec. I just need to slide forward. Okay. So I'm going to go ahead and share my screen again. All right. Okay, so these are the questions that I received. What would be the appropriate way for health staff or clinician to ask to identify yourself? So we definitely covered this. Hey, what are your pronouns? That's like a great one. Or even better, if you have name tags at your front desk, and you can also have pronoun options. So you can have a hi, my name is, and my pronouns are. But it may or may not be safe for someone to publicly identify their pronouns. They may want to keep that as like between you and me, but I don't want my family to know. In the same way that there's a lot of other sensitive information, you might find that you're at risk for intimate partner violence because you're already experiencing intimate partner violence. And if you told your abusive partner that you don't identify as a woman, you would be in trouble. You would be in danger. So, but you may want and need to feel honest with your provider because that's a safe space for you. So, making sure that you're checking all of the other things that we check as care providers. And when you ask about pronouns, say, is it okay for me to use those pronouns publicly? Or would you like me to keep that between us? You can definitely say that or ask that on an intake form. It's not going to offend anybody. It's going to show that you can recognize that it may not always be safe for people to identify themselves in a public setting. And screening tools, inadvertently excluding but needing specific data for EPIC. Oh, EPIC. Oh, EPIC. What to consider? Well, instead of using the Edinburgh screen for perinatal depression, you can use the GAD-7, the GAD-7, and you can use the PHQ. Neither one of those are gendered screens, and they have been validated in queer populations as effective. So those are the ones that I use. I also use the brief PHQ. I find it's really effective when I'm doing screening. And so if you have other screens that are gendered, you have a problem that we all have, which is the lack of research. You have to understand that in the demographic data we have a couple of challenges. It's not safe to identify. So you're going to pick woman, but maybe you're not, but you're just going to pick whatever's not man. Or there's no list. There's only the two options. So if I'm participating in a research study and there's not an option that fits for me, I'm going to have to pick one, but it's wrong. So now the data is actually wrong, but it's on the people who designed the study or designed the screening tool. So we have to do the best with what we've got. And what you can do is identify and say, I know that this is a gendered screening tool. I don't have something different. So if you could pick the best thing for you, or if you could give me that information in a different way, we'll go through the screen and I'll update it and I'll make a note in your chart. Cultural terminology. This one is a big one. I have lots of friends in the South, and I know how important. I'm a Californian, so I'm sorry, but ma'am and sir didn't even enter my terminology until I started making friends with people in the South. And so, yes, ma'am, or yes, sir, are very important pieces of the culture, though. And so, what do we say? And so, what is an appropriate way to address somebody? Also, something like being warm. I think somebody mentioned saying, "Hey, mama, like it's okay, mama, you're doing a great job, mama." How do you make somebody welcome if you're not knowing their name? That makes such a huge, huge difference. And so, the way that I would answer that is saying, asking the person, say, I don't want to call you, I know that you're not a ma'am or a sir, but do you have an honorific in which I could use to address you? Or, um, you're doing a great job. You're doing a great job. What parent name do you use? What's on my intake forms? They say, what's your preferred parent moniker? Because that is a preferred thing because you choose the parent name that you use with your kiddo. Although sometimes your kids choose it for you, though. So, and parents love talking about that. That is one of my clients love that question. They're like, until I read that question, I didn't even think I could pick a different thing than mom or dad. And I'm Abba and I love it. And I love it. And I'm like, yeah, good job, Abba. You're doing great. Oh, this baby loves their Abba. And you gotta ask. I know it's scary to ask, but no one's gonna bite your head off. I promise. Even just asking shows that you care, which is a huge thing. Terminology of anatomy. There's actually a whole paper that just came out about this, and I'm going to leave my feelings off of this chat or off of this talk. But chest feeding is not specific enough. Yes and no. Chest feeding has been used in Spanish. If you think about dar pecho, it means to give the chest. It's been used all over the world, but we don't need just chest feeding. I actually use body feeding because it's more inclusive, because chest feeding leaves out those who identify as having breasts. Now, chest feeding can be specific to your client if your client does not identify with the terminology of breasts. And it's important to understand that anatomical terminology in client care settings is the number one trigger for dysphoria. Dysphoria can be fatal. In fact, it is fatal when untreated 85% of the time. So it really matters that you use the terminology that aligns with your client's identity. And so I like body feeding or nursing. Nursing is great. In fact, I just bought a book. I'm going to just grab it. And I don't agree with all of the clinical stuff now, but that's, what clinicians, none of us are all going to agree on approaches. But it's written by Liesl Burish, and it's called Queer Nursing, and it addresses this topic specifically. And it is a really great text or reference to have on hand for yourself. And it's actually written for parents. So it helps parents to feel included and seen, so that they're not having to just make that Womanly Art of Breastfeeding book work for them. And I know this is how you speak to it in XX clinic terms, but in our system, we have to document with a medical term. What is a more delicate way to have that conversation regarding medical terms and body parts and what goes into a healthcare system? 100%. That's a hard one. I say internal or external gonads. I say instead of testicles or ovaries. I still say uterus. I still say vagina. When charting is different than in direct clinical care, and I guarantee you that the client that you're working with is not unfamiliar with the terminology that's been used and that medically needs to be used. And you just identify that. Say, I got to use this EMR. It only has these options. I have to say this, but I want you to understand that I affirm and hear and believe in in making sure that you feel welcome and cared for and seen in this office. And so I want to make sure that even though I have to say this on the chart, in anything that I give you that I have control over, I'm going to make sure that I'm using the terminology that is aligned with your identity. And you can ask people what they use. I have a client who's chest feeding, and he doesn't like to call his nipples and areolae. He says he calls them his magic buttons. And great, that's great. We'll use magic buttons. Am I going to use that in my chart? No, but I will also say this is what we're using terminology as a chart note, so that anyone else who takes, any of my other clinicians in my clinic, sees that person, then they're going to make sure that they're using the right terminology too. It's up right next to allergies and other important things, because it's important. And how can we educate nurses? Oh, sorry, being exclusive. If we say birthing parent versus birthing mother, finding a balance to keep moms centered. Well, moms aren't the only ones that need to be centered. Moms have been centered for a really long time, and no one is decentering moms. We're just asking them to scoot over and share the space with everyone who's birthing. So birthing parent, mothers are parents. Parent is inclusive, you can say that. Or if you know this person is a mother, then you're speaking directly to them, then call them mother. In the same way that if you know someone's not a mother, don't call them mother. So if you're speaking to a large group, you're going to say birthing parents, because that includes everyone. And you also can say birthing parents and mothers, or birthing mothers and parents. You can expand your language, because inclusivity is not, it's not like pie. There's not, if you cut more, there's like less, right? If you take a piece and there's not enough left for someone else. It's actually, it's like a candle. So if you take your candle and you use it to light another candle, you don't now not have fire. It's just that there are two lit candles. When we use inclusive language, we're lighting candles. We're not taking things away from other people. But when you've been centered in a place for a long time, and when you have a lot of privilege that you don't recognize, it does feel like you're being ignored or oppressed or forgotten, and when you have to share. And I absolutely can understand and empathize with the cognitive dissonance that happens there, but I also can assure you that including others with your language and just saying a longer sentence is the way to go, that doesn't end in people not seeking care, not getting care, and um, and worse. And so how can we educate nurses what is safe or not safe regarding what if someone needs to know if they're transitioning, what someone needs to know if they're transitioning, so we're educated and keeping them safe as well. I read this one earlier. I don't feel like I understand what this means. I think you were talking about HRT maybe, and hormones, and like the impact of hormones on other things. Um, Understanding that if someone is doing a DIY at home lactation induction protocol, like the Newman Goldfarb protocol, for example, lots and lots of queer nurses have taken that on and used birth control for it. It's important to know what medicines that they're using, because progesterone increases can have concomitant comorbidities, like side effects such as pulmonary embolism and strokes and clots and things like that. Same thing with the estradiol or estrogen increase. We also know that a sudden sharp increase in estrogen or progesterone levels can reduce the effectiveness of antiretrovirals or ARV therapy. And so that's an important thing to know if somebody is HIV positive, for example, or if somebody has herpes and uses antiretrovirals for that. So you're going to want to make sure that you're paying attention to the interactions between their med list and what you're doing and what they're doing and what's changing. So in the same way that you would be with anybody else too. There are lots and lots of cisgender people that take progesterone and estradiol throughout the fertility process, and we have concerns, same or similar concerns for them. Understand that hormone balance is hormone balance. And then how can nurse champions have these conversations with health staff to prepare to take care of a patient that identifies in that group? And how can we tailor care to be more respectful? I loved this question. You can start by asking. The answer is always inside the community. So the answer is always with us. Now, one person, including me, does not get to speak for all queers, but that person does get to speak for their care. And when you're talking with other colleagues about care, one of the things you can do is the best thing you can do, like we talked about earlier with practicing pronouns, is modeling. So you can say when you're handing off, for example, you can say, okay, I've got this person in room 13 and they use they them pronouns. Their parent name is Abba or Opa or whatever, and we had a conversation and I let them know that I had to use this anatomical terminology in their chart, but when we're having conversations with them, this is the language that they identify with. So when you're having a care conversation or an educational conversation with this person, please use these words instead of these words. Please use chest feeding, for example, because that's really important to them. And then you can also share with your colleagues. There is, and I'm happy to send it to Suzanne, there are lots and lots of research articles that show the outcomes of medical care when it's inclusive versus when it's not, and also the outcomes of dysphoria being treated and untreated. And understand that hormone, gender affirmation hormone therapy, GAHT, sometimes also called HRT, hormone replacement therapy, it is a huge and important step in treating dysphoria, as well as therapy and supportive environments, supportive care environments. So when we have clients who can trust us, we have clients who can get help from us. Because if your client doesn't trust you, they're not going to share with you all of the things that they need help with. And you may run into something catastrophic because they didn't feel that they were safe to share. On that scary note, I also think that you're going to do just fine. These questions were wonderful. These were not the same basic questions I get all the time. And I wanted to just identify that I'm so thrilled to be here and amongst a group of people who are so caring and who are so motivated to be helpful and to be good care providers. I'm going to stop sharing my screen. And if there are more questions and if we have time, I'm happy to answer them.
And I will note that we are over time. If anyone is able, no, this has been wonderful. If anyone is, we're willing to stay and to answer a couple of questions, that would be great. I also put our evaluation link in the chat. So please do share feedback on today's session. And if you do have additional questions, I know I have some resources to share after this. We have this recorded. I'm keeping my eye on the chat in case a question comes in. But feel free to send me a question.
Question. My name is Lauren. I'm a medical student who is hopefully gonna be starting a OBGYN residency, not this year, but next year. And this talk has been super helpful and almost more so than kind of what we get in our curriculum as medical students on these sorts of things. And just today I drove past a women's health center and kind of had the same thought that we talked about earlier, that, wow, that's really not inclusive. Do you have recommendations for alternative language other than women's health center that still signifies kind of the services that are given there? I know you mentioned perinatal, which I really like, but even that doesn't always incorporate patients or clients who are not planning on having children or kind of in that part of their life. If you just have any recommendations, I think I would really appreciate that.
Yeah, thank you so much. And congrats on like getting through med school. That is like a ginormous undertaking and I applaud you for that. And also thanks for even thinking about that. And yes, actually there is a grassroots program. It's a grassroots group of med students, actually, they're workshopping more inclusive terminology to be identified, identifying what's happening. Sexual and reproductive health is one of them. And, there are lots and lots of different ideas being thrown around in the community. So I will get the information for that group because I cannot remember it off the top of my head, but I can get it to Suzanne. I'm going to make a note on a sticky right now for you.
Okay, yeah, thank you. That would be great. I kind of have thought about it this morning and I haven't come up with any great ideas. So I would really like to see what other people are doing, because I know just kind of in general, kind of thinking back over the last several years, the women's health has definitely become like a coined kind of buzzword that is not appropriate to use for sure. So that would be great. Thank you.
Yeah, thank you so much.
Good question, Maureen. This has been really helpful for me as well. I've taken a lot of notes about different words, especially with content writing we do for our website. And a lot of times I'm always worried about too much text. So this has been helpful of different things you've said that have kind of prompted ideas for me to even phrase things.
Yeah, and I know it's an editor's nightmare for sure. You're usually supposed to say less, but you still have to say the essentials. So thank you. And thank you for thinking about it. And thanks for letting me be here, honestly, and talk about it. I hope, and if there's any feedback at all, or if somebody has a question that they don't feel like they want to ask out loud and they want to ask privately, I'm so open to that. I'm also so awful at checking email. So you're more than welcome to share my email, Suzanne, and I will get back to you at some point, I promise.
All right, well, I so appreciate your time and your energy, and so grateful for all that you taught us today. Please do submit the evaluation and then I will be following up. All right, everyone, have a good week. Take care.
Bye.
Bye, everyone.